Maybe to start off my presentation, I could go back a little bit further than that. When I trained, it was actually down in the south of England. I trained at Warley Park Hospital in Croydon. And it seems to me that in those golden days, perhaps, I might be a little bit nostalgic, but it seems to me that acute psychiatry was a very different animal to what it is now. I think we were much clearer on the purpose of acute psychiatry. That was possibly because we had less alternatives. I'll just wait for Hubert to rejoin us.
Yes, I'm already here.
That's good. All right, Hubert, I've just got started.
Sorry.
That's okay. All you missed was my introduction. Okay. Yeah, at that time, 20 years ago, I think in acute psychiatry, we were very clear on the purpose of acute psychiatry. I think we were perhaps, although there were some patients that came to hospital that there were inappropriate admissions, it seems to me that we dealt with those people fairly quickly. It seems to me certainly that the status of the job was much greater. I recall as a student nurse that you didn't apply for a job on the acute wards, you were actually chosen. And if you were chosen, it was a mark that you were actually going to go quite a long way. You'd probably do 2 or 3 years there, but you'd be into a decent career journey quite quickly. Now, it seems to me now that acute psychiatry is a far more difficult job than it was then, for reasons that I'll explore in a moment. But the first thing, from the staff's point of view, is that the status has gone. That, if you like, the clarity on what we're doing, the idea that acute psychiatry should be a high status, high skill arm, if you like, of the service, doesn't now seem to me to be as prevalent. In fact, we've got so many alternatives to working in acute psychiatry that it's no wonder that an awful lot of people actually move out of the wards to take alternative jobs where they probably enjoy, in many cases, better salaries, reduced levels of stress, and probably increased levels of professional autonomy and decision-making control, if you like. So there's any number of good reasons why the bright sparks, if you like, don't want to remain in acute psychiatry. I think for those that do, though, you have to say that working in these wards is a genuine commitment. It's not an easy job. I think it's something which only recently has been recognised by departments of health, that to work in these wards actually does require a high level of skill, and that you're facing levels of stress and strain, which many of your mental health colleagues actually won't be facing. Now, if we look at the stresses and strains that you're facing for a few moments, still with my rose-tinted glasses on of 20 years ago, it seems to me that the nature of the patients that we're serving has changed greatly. We have far more challenge, I think, now from people with personality disorders. Drug use, well, of course, there was recreational drug use 20 years ago, but perhaps going back even 5 or 6 years, you'd be a very smart mental health nurse if you could even define what dual diagnosis was, or if you'd even heard of the term. Now, I would guess it's something like, I don't know, you tell me, guys, about 75% of your patients are using street drugs, I would have thought, possibly higher. Nearly all your psychotic patients are going to be using street drugs. We know what that means. That's likely to lead to people being more disturbed, less likely to respond to treatment regimes. It's more likely to make people unpredictable. The link between extremes of behaviour and substance use is very clear. It's likely also that people are going to be engaged in a rather sort of anti-authority sort of culture. It may well be that offending is a regular part of the lifestyle of many of our drug-using, substance-using patients. So that's one change. The issue about personality disorder is another interesting one. I think these are people who, to use a cliche perhaps, the squeaky wheel gets the grease. These are people who many of us feel, I'm sure Len can advise us on the research on this, but many of us feel that these are people who are probably not well served by coming into acute environments. They're probably not well served by coming into environments where there's both a system which takes responsibility away from the client and a system in which it's very difficult to, once these people are engaged, to actually disengage them. Much as we'd like to actually keep a very close eye on the very poorly end of our patient population, many of the people that actually seek admission in acute wards would be much better served by staying away. But it's my view, and it's nothing more than a personal view, it's my view that admit once and you're likely to admit again and again and again. And it's also my view that the longer those admissions tend to be, the more likely people are to come back, and again, the more likely that their admissions, again, will become very lengthy. This is a patient population who are particularly good at testing the system and exposing weaknesses between us as individuals, and systemic weaknesses as well. And I think to a certain extent, we've not responded to those changes. Many of our practices, we still do what we did and what seemed to work well 20 years ago. Take, for example, ward rounds. For me, ward rounds with a large group of people is nothing more than an institutionalised lack of trust between professional people. Because if you had trust, then the doctor wouldn't insist on seeing people for 10 minutes and making a clinical decision which might be a variance with a clinical decision made by the nursing team who've seen those patients for 168 hours in each working week. It seems to me that that sort of old institutional practice is something which has failed to take account of the changing needs of our patients. And those teams that actually do have doctors that turn up every day and make a decision sat on the desk in the nurse's office, drinking coffee and eating a sandwich, are probably more likely to be robust, fast-moving, and there's likely to be greater trust between the professionals involved in making those decisions. My evidence for many of these things is just purely anecdotal, and again, I'd refer to colleagues who are immersed in the research base in this field. But one of my anecdotes concerns two teams that work in one of the trusts that I work with. I won't say their name because it wouldn't be ethical, and it's also bad business as an independent consultant to say this trust are rotten and this trust are great. The ones that you say are rotten don't tend to employ you again. But actually, in this particular trust I've got in my mind, they've actually got one service which is really performing brilliantly and one service which is not in the same trust, which is very interesting.